So let me go on to introduce Dr. Saag, who you've already met today, so I'm not going to spend a lot of time going over his accolades, but he is going to be presenting challenging cases in antiretroviral therapy in a panel discussion. And we have several other panelists today joining us. Rafi Landovitz from University of California, Los Angeles. I've already mentioned Dr. Saag. We have Roger Bedimo, and we have Matt Feinstein. I can't see who's all the way down at the end. Kim Morkowski has joined us. We were supposed to have Monica Gandhi, but I don't know where Monica went. So we'll have to forge on without Monica for the moment. So Mike, I'm turning the podium over to you.
Great, thank you. It's good to be back. Paul, you look like you're feeling better today. Good, that's great to see. So these are, for those of you who've seen this before, it's really case-based. I am going to highlight some things that you're going to be seeing a lot more in depth in some of the questions. I'll go through those kind of quickly, but this is kind of meant to pick up as a kind of potpourri topics about antiretroviral therapy and some of the complications. So I've served as a consultant for these two companies. And we're going to go over antiretroviral therapy for initiation and change and issues of weight gain and pregnancy and or anabacavir regimens. We're going to talk about managing the cardiovascular risk as a little tease for Dr. Feinstein's talk later this afternoon. Talk about STIs and particularly look at doxy, which is a prep for Dr. Wolkowski's talk. And then MPOX, we talked about that a little bit and talk about COVID. Well, we'll tap into Dr. Volberding to see what this all feels like, although I think most of us probably had it, and it's no fun. So let's talk about our initial regimen. I'm going to turn to the panel in just a second. So we got a 48-year-old guy who presents newly diagnosed. His viral load's 280,000, CD4 count 65. So I'm going to say you have this information when he shows up, not like our usual where we just sort of assume we don't have the information. The other labs are normal. We get a wild-type virus, normal renal function. He's okay to start therapy if you want him to, and of course you do. So what regimen would you use? I'll let you look these over and kind of pick it up. Viral loads over 200,000, CD4 counts less than 100. I'll have to hum some tunes. Okay, so which regimen would you use? I don't know if we have music, but maybe we will for the next one. We do. We just got to wait for it to queue up. Oh, anybody know this? Welcome to my little town. Anybody know this? Nobody. Apple TV, Dr. Landovitz.
Apple TV.
Schmigadoon season 1.
It's Schmigadoon #1, yes, it's good. All right, let's see what we got here.
Here all week, 2 shows nightly.
Okay, so the majority of the audience goes with BIC, TAF, FTC. Panel, Dr. Bedimo, what were you thinking here?
Yes,
Use a microphone.
Following the wisdom of the group, this is somebody who has no significant comorbidities, and we don't have baseline labs, and so we want to make sure that we have them on a regimen that is likely to work for most. So I agree with TAF, FTC, bictegravir. 3TC dolutegravir, a Gemini study has also been shown to work. This is somebody whose initial viremia was less than 500,000, and that's good. Now, as we said earlier, abacavir, 3TC dolutegravir, we still have a concern for people with possibility of high cardiovascular disease risk. So we don't know. The main problem with TAF, FTC, or valtegravir cobicistats include whether somebody is going to have other drugs that the pharmacoenhancers might be a problem with. Also, darunavir, ritonavir plus dolutegravir, not something that we have studied a lot, but since we've seen it work in the DEF2 study in experienced people in Africa, I think it just might be workable as well. So I think that all these options are on the table with pros and cons that we can discuss more. I think the main thing to see is, what is the cost if you start what is in green here, if very little missing.
Okay, so we've had Dr. Gandhi has just joined us. She's from UCSF. And I'm going to turn right to you just to start us off, because there's two things on here I'd like you to comment about. Just based on prior conversations, I know that you in general are like on initial regimens to maybe lean towards darunavir. So maybe you can advocate for that, or
Actually, our position on darunavir at Ward 86 is more for patients where we're concerned about adherence. And so here I see that this patient has advanced HIV. But where this comes from is there were 4 studies last year published: the Vicen study, the Nadia study, the Donning study, and the 2SD study, either in abstract form or publications, that looked at, if you have NRTI resistance, what regimen should you use? Dolutegravir-based regimens versus boosted PIs. And there were different boosted PIs. Donning was lopinavir, ritonavir, and the others were essentially darunavir, ritonavir versus dolutegravir. And even though dolutegravir retained its place as should be second-line therapy, first-line and second-line therapy worldwide, even in the face of NRTI resistance, dolutegravir is going to work. If you failed with dolutegravir, especially in the Nadia study, you were likely to fail with dolutegravir-based resistance. 9 participants in the Nadia study failed with dolutegravir-based resistance compared to darunavir, ritonavir, where no one had PI resistance. So what that really led us to think is that if a patient, really can't take their medications every day, it's 4 or 5 times a week, in the setting of documented difficulties with adherence, we favor darunavir, ritonavir over dolutegravir.
Right. So a lot of your work recently is focused on that more difficult population. So the case I presented was kind of an advanced HIV with a CD4 count of 65 and a viral load of 200 and some odd thousand. And so if you're worried about adherence, then you might lean away from a strand transfer inhibitor. Last option there on the, just because we've got you here and I want to take advantage of that. Let's say you have somebody, let's make it a little bit easier, somebody who's got a viral load of, let's say, 40,000 and a CD4 count of 230, and you're real worried about them. Let's say they're homeless and you aren't 100% sure about their adherence in the long run. What about we normally use injectable cabotegravir with olpivirine after someone has achieved viral load suppression, but you've done a pretty innovative study, and you'd be the first to say, not ready for prime time, more exploratory, of looking at direct to inject, meaning you just start them right away. So maybe you can tell us about that briefly.
Yeah, so briefly, we were all talking about this before long-actings came out. Can we use this for adherence-challenged patients? Antipsychotics, contraceptives, really long-acting had a benefit if you had a hard time taking a daily pill. But FLAIR Atlas 2M, the registrational clinical trials that led to the approval of long-acting CAB and rilpivirine, you have to be suppressed on oral therapy for at least 20 weeks before you go to injectables. We have a patient population that has a high rate of homelessness, 34% at Ward 86, and we decided to just try it. Use long-acting cabotegravir and rilpivirine, even in this patient, someone who cannot take oral ART, just has documented cannot, even if they have viremia. And presented our demonstration project at CROI. It's about to be published, but really showing that even in patients who with viremia, it was a small study, so like you said, we need bigger studies, but even in patients with viremia, there was a very high rate of virologic suppression because they couldn't take the oral ART. It's almost unethical to say, give you oral ART if they've documented they can't. So about essentially a 98.5% suppression rate in that small group of patients who are viremic.
Right, so we're first to say this is off-label, so we have to do that for CME purposes, but I think it is, I think, a tribute to you and your team for thinking out of the box on what to do in these very specific outlier cases where perhaps you might have tried a darunavir regimen up front and they failed not because the drug just didn't work or there's resistance, but because they didn't take it. And after they fail and they come back, then you might use this option even though their viral load is detectable. Right. Okay, so I think we've been clear there. Let's move on. There's the antiretroviral guidelines of IAS-USA that came out in December, and the HHS guidelines are there. So let's kind of pick up from Dr. Benson's conversation at the first of the thing, and let's go back to the future with Doc Brown and Marty McFly. And let's look at the regimens. There's our same guy on the right-hand side, so you've got a lot of information. But now you've got new drugs. The islatravir doravirine is an option, and islatravir lenacapavir, which really hasn't been studied. It might be every 4 months, every 6 months, I mean. BNAbs you heard about with lenacapavir, early data. Implantable. We didn't talk about that, but you could do it like we do for progesterone, for contraceptive treatment with an implantable that you can take out. What is most attractive to you, understanding we don't have data? Just go ahead and vote. Whoops, yeah, there we go. Oh, we're still in Schmigadoon. This is corn pudding. And if you've got some extra, I sure would like a taste. Yeah, that's probably one of the better songs in the thing. Okay, let's see what we got. Ooh, the implantable seems to win, even though it doesn't even exist, but it's attractive, isn't it? Well, I mean, I think it's attractive for two reasons. One, it's every 12 months. And even those it'd be a surgical procedure, just kind of implant 1 or 2 stitches and you're done. People in GYN have been doing this for quite a while, right? Maybe a couple decades. But what's also cool about it is if there's an adverse reaction, you just pull it out and it'll clear, as opposed to something you shot into somebody's gluteus that you can't really exactly remove. So, Connie, why don't you chime in here of what is resonating with you out of these choices?
Well, that one resonates with me.
Yeah. Any thoughts about just using sub-Q? It doesn't exist yet for islatravir, but it might.
Yeah, I think sub-Q options on microphones.
Yeah. Yeah, try Rafi's there.
Yeah, so I think the sub-Q options, I think, are also potentially attractive.
Yeah.
People don't have much trouble with sub-Q with diabetes and a host of other diseases that they take sub-Q medications for, so that's another attractive option. But as we're all talking about it, I think we're really into the long-term injectable materials. I think IV infusions don't appeal that much to me. So, as I said, the broadly neutralizing antibody approach is kind of iffy in my mind.
Right.
You'd have to set that up through an infusion center, and all the complications thereof likely to be much more expensive. So I like the implantable and sub-Q approaches.
And I can't even begin to think what that cost is going to be, but yeah, boy howdy. Monica.
I just wanted to mention lenacapavir and cabotegravir together. And it's not on your list, but the reason that this keeps on coming up in conversation is lenacapavir at the moment, and I know this is 3 years, this is a great time, implantable and all that, but at the moment, lenacapavir doesn't have a long-acting pairing. And as Dr. Benson talked about in the Calibrate study, we're not going to get this approved for naive patients. That wasn't even powered for naive patients. So this question of lenacapavir, what's the closest thing at this point to be paired with that's as long-acting as you can get? It's actually cabotegravir every 2 months, lenacapavir is every 6 months, and there's so much NNRTI resistant, or at least low level around the world, that this cabotegravir-rilpivirine combination has not been approved by the WHO for treatment. And so I think people are increasingly, because lenacapavir is now available as of December 12th, 2022, getting it, and we have 18 patients in California on lenacapavir and cabotegravir, and putting it together.
Right. So I just had a patient this past, come to the microphone, or there's over there.
So,
repeat the question.
Do they have rilpivirine resistance? So there are 14 patients at UCSD that they've shared their data on, and then we have 7. In our case, it was either that they had, yes, NNRTI resistance, and for example, I just put a patient on lenacapavir, cabotegravir, who's had HIV for 35 years, cannot take pills anymore, just cannot, and had so much NNRTI resistance.
Right. I just had a guy literally this week in clinic on Monday who was is a transplant recipient, but unfortunately the donor kidney was a HIV to HIV transplant. The virus that became dominant was a donor-derived variant that was resistant to strand transfer integrase inhibitors, and we couldn't use any kind of boosting agent, and it was also resistant to non-nukes, so we used lenacapavir as a base, and then went with one of the more active non-nukes, and I think it's going to work, but I was tempted to pull out some TAF because I didn't know what to use there, and even though he's got a renal transplant, you know, sometimes you got to do what you got to do. Kim?
Yeah. So I've got a couple of things. I think it's wonderful to have choices.
To the microphone.
I think it's wonderful to have choices, but I think that trying to put everybody in a bucket is not the right way to think about. And especially when you're thinking about worldwide and you're thinking of the incidence of hepatitis B. And you have to be cognizant of that.
That's right.
In terms of your choices and if people are at risk. Especially what I see with the hepatitis B, and we've had a couple of recent cases of sexual transmission, that people are not vaccinated, they're not immune. So I think the point is that you have choices like anything else, and you have to sit down and offer your patient the choices. And sometimes on the first visit, you don't really know, right? You're trying to develop this relationship with them, and you don't really know. You're trying to figure it out together, and then you can change over time as things evolve, and things evolve with comorbidities as patients are living longer and things. I'm really excited about having choices, truthfully, and that you're able to offer, this is what I have to offer you, what do you think, as time goes on.
I think, I'm really glad you said that, because I think we don't want to get into a just one size fits all. We have to mix and match, and I think that's certainly what Monica and her team have done out there. There's 2 quick questions I'll take real fast. Is that, do you know if in the setting where people can't take oral medicines, would the injectable cabotegravir rilpivirine be covered by insurance? And generally, yes, but it's hard.
It's hard. It's actually easier to get it on public insurance than private right now, which is this irony.
Right. And then what about resistance to cabotegravir? It's basically the same as dolutegravir, is a way to think about it. So let's move on to simplifying regimens.
Mike, just before we do, can I interrupt?
Go ahead,
so if anyone is thinking about doing what Monica has sort of told us about in this interesting combination of cabotegravir and lenacapavir, Monica, how are you getting the cabotegravir? Because you can't get it as monotherapy unless you're using it for PrEP. So are you getting cabenuva and tossing the rilpivirine? Or
correct. So we're getting the cabotegravir.
You didn't hear that.
Okay, so I'm sorry. So it's actually, Kate, we were just, I was just at a meeting in India, and I will say that in India, you know, because ViiV signed on to the Medicines patent pool, they're making cabotegravir for the world. But then what do you put that cabotegravir with at the moment? But you're right, in this country, the PrEP formulation, 600 milligrams PrEP formulation every 2 months, I can't get it to give it with lenacapavir, so you get the cabotegravir, rilpivirine 600, 900, and you toss the rilpivirine, so it is a waste.
Okay, so our next is a case is a continuation of the first case, same person, but he got started on dolutegravir TAF-FTC, and after 4 months has gone to undetectable, had a nice bounce in the CD4 count. And the question is, would you be Herbert Walker Bush and not going to debt, not going to change, wouldn't be prudent, or might you change to one of these other choices? Please vote.
Mufasa.
So I used to call this Sestiva Truvada instead of Hakuna Matata, but Sestiva Truvada, I don't know why they didn't do that, but Lion King I don't like because it beat out Ragtime for the best musical that year. So most people wouldn't change. Some people would go to injectable. What say ye all?
It depends.
Rafi.
Again, coming back to what Kim said before, I think you have to have a conversation with the patient. You know, if they're doing fine on TAF-FTC, dolutegravir, there's certainly nothing wrong with that regimen. You haven't said there's a toxicity, correct? So if it ain't broke, don't fix it is certainly a reasonable approach. They are undetectable. So cabotegravir, rilpivirine would be an option. I think you said that they're Hep B negative. We know that now, right?
That's correct. They're hepatitis B
They're
immune.
Okay, great.
Yeah, I said that.
You didn't say that before, which would have made us less excited both about the second and third choices there. You know, dolutegravir plus 3-TC, you know, we certainly know works very well for initial treatment, so it probably will work okay for switch.
Should work well.
So any or all of those, I think, are okay, depending on what the patient wants to do, what it's going to cost them, what their insurance is going to allow. If this 2 pills versus one
so
thing
you're
is...
going, I mean, you could have started on a fixed dose of bictegravir, but this, for whatever reason, started with dolutegravir with 2 pills. So going down to 1 pill would be less expensive, fewer co-pays. Others, Monica, you look uncomfortable down
Because
there.
we have to talk about side effects actually for a moment, in the sense that dolutegravir and bictegravir are first-line therapy for a reason. Really highly potent, high genetic barriers to resistance. So now we almost have the luxury to talk about adverse effects, side effects, metabolic profile, weight gain, and really think about that. So there was a study at CROI 2023 that showed, from Amsterdam, that showed that if you do take away that TAF, you do get better, you get improvement in cholesterol and you get improvement in lean trunk mass. And then Dr. Badimo presented the Characterize study. I know that was going to TDF, not you know, TAF, taking away the TAF altogether. But there is this element of TAF and its impact on metabolic effects and weight. And so that number 2 kind of looks somewhat nice in terms of a long-term effects on weight and cholesterol.
Right, it depends on, go ahead, Roger.
And then to complete that, I agree, is that switching to the third dolutegravir plus 3-TC has not been shown to impact the weight. It's the same weight, but improvement in metabolic parameters, lipid and glucose. So it's possible that you may have benefits by
Right. So let me move on. And
So, Mike, just
it's a good setup. Go ahead.
One other point about the cabotegravir rilpivirine regimen is people need to remember that the injectable, this particular injectable regimen, right, it carries with it a small but real rate of virologic failure despite on-time injections. And that failure is often accompanied by dual-class resistance to both agents. So people are very excited about the benefits of this injectable regimen and life-changing ability to not have to take pills every day and be reminded of a diagnosis that's so stigmatized still in our communities. But it does come with a price. This will not be the only long-acting injectable regimen we ever have. It's the AZT of long-acting injectable regimens. But I think people really just, that needs to be part of the counseling, that this isn't a slam dunk.
So
switch.
quantify, it's what percent? It's like 1%?
I thought 2.
2.
1.4% in the 150, to be right in between you guys.
Do I hear
'cause
1.3?
because the 152-week data was presented at ID Week by Chloe Orkin, so it's 1.4%
Yeah.
across flare.
So
apples to apples.
when it happens, it's could be bad, but it's like me getting my knee replacement, right? That's prosthetic joint infection, 1.4%. Yeah.
But the other problem is I've had 3 cases of very serious pancreatitis associated with ropivirine. And so very serious. And so I'm very nervous about that. And I also, I've seen a lot of recent injection fatigue. We talk about pill fatigue, but there's also injection fatigue. People that have had pain for several weeks after their injections, and then they have 2 weeks free, and then they're set up for another 2 weeks. So you have to really seriously think about that as well. It's not just the liberation from a pill. It does have consequences.
So it goes back to what you said earlier. It's good to have these choices. And
Right.
part of the choices is informing the patient as you discuss with them. There's a 1.4% injection fatigue. We have a lot of people coming back for bicillin every other month. And so that gets fatiguing as well, which you'll talk about a little later.
Yes, we will.
Okay, how is, picking up right on Dr. Badimo's point, we're going to turn to you, Dr. Badimo. This is a woman who started Big TAF FTC, similar to our last case. Nice response, great response. But currently her weight has increased from 145 to 171. And we'll move on and let you look these over, but one is, again, don't change anything or change to something that's listed here. Let's go ahead and vote and see what kind of music we get this time. Okay, so, all right, most people, it's interesting, switcher to dolutegravir, TDF, so getting off the, so Dr. Badimo, help us decipher what might be, she's real worried about this. I mean, I guess you could start semaglutide or something, but short of that.
No, I think that the number one thing before we get to this point that we ought to do with a person like that is that we owe her candor before we start antiretroviral regimen so that we don't face this problem. That the candor is to tell them we don't know whether they're going to gain weight. We know that they're more likely to if they're women or non-whites, but beyond that, we have very little understanding, so that there's no surprise. Now that this has happened, there's a frantic search for what to do, or whether that weight gain is reversible. Thanks to the characterized cohort, we think it just might be, but this is extrapolation because that was dolutegravir plus FTC TAF, but this is bictegravir FTC TAF, but we think that's a possibility. So according to that study, if you switch that patient to a regimen that removes the TAF and maintains the dolutegravir, there's possibility that they lose some weight. If you switch them to dolutegravir plus 3TC, it's possible that they will not lose weight. If you switch them to TDF-FTC doravirine, we're waiting for an ACTG study that will tell us if that will be the case. And I hope it enrolls a little faster than it is now. And because we really need to know, because this is the one option where you're removing 2 possible offenders, i.e. integrase inhibitors and TAF. It's possible that removing both would be resulting in weight loss. Now, if you look at other studies from SALSA to others, I think you have to be cautious that it's possible that the trajectory of the weight will be different based on how long they've been on the offending agents. It may be possible to reverse if they haven't been there for more than a year or so.
So the bottom line is we don't know, right? I mean, you did a nice job.
It was a long way of saying I don't know.
But I think what we can say for sure is that going from bictegravir to dolutegravir ain't going to make a lot of difference. So that's maybe not a great choice. TDF, yeah, that might be helpful, but so far it hasn't really been shown to have a dramatic effect, and we'll see in the new study, you know, getting to, we know what is associated with more steep inclines in weight gain, that's strand transfer integrase inhibitors and TAF, but you see it with basically every regimen. So I think it's prudent as we initiate therapy just to kind of give a heads up, right, as we prescribe things, whatever we decide with the patient, and look out for this as we go. Yeah, I think that's kind of where we are. I think we'll move on, but let's move on to pregnancy. We have some experts in the audience who's welcome to come to the microphone. So this is pretty straightforward. A woman newly diagnosed, and when she went in for prenatal evaluation at 6 weeks, had a viral load that was kind of low, CD4 count high, and we had a B5701 just because, and it was negative, and a wild type virus. It's her first pregnancy, and she wants to start therapy. So what is the best, today's world, best initial therapy? And I'll give you a heads up, there are some wrong answers here. So there's a, you know, like in the board questions where you get the ejector seat if you pick one? I'm just putting pressure on you now as you go, so go ahead and vote. Yeah. Okay, let's see what we got here. Oh, so a pretty well-informed audience, but maybe missing a few points, and no one went for the ejector seat question. Yay. So cobicistat would be a no-no.
Yes.
There's no data for it, and it's not a good idea. Commentary. Who wants to take this one? Monica.
You know, I think what was really helpful is that fundamentally what happened with the DeSamo cohort, which was the study in Botswana that showed a possible observational cohort increased risk of neural tube defects with dolutegravir. More observations, that so completely went away that this is, you know, always should be first line, and it literally, you know, derailed rollout of dolutegravir for women for a full year. So that was a difficult thing to see. But actually, everything works well in pregnancy except for COBI because of decreased levels. COBI just doesn't boost the either alvategravir or the PI enough. The levels truly go down the third trimester. But the question had always been about TAF, and now we have studies, you know, from the IMPACT cohort really looking at efavirenz TDF versus FTC versus dolutegravir TAF FTC, that dolutegravir TAF FTC actually looked better in terms of some pre-weight, preterm delivery, and other outcomes for the baby. So at this point, TAF is as good as it gets for pregnancy. And then BIC, we don't actually have a lot of data on, but there's no theoretical reason to think that it would do.
The way it's emerging, that until more data, and they're coming, right? More data.
It's more that I think the world has come to realize is that unless there is I understand what happened with thalidomide, and it was a terrible thing, but unless we enroll more pregnant women in clinical trials, we should be really justifying exclusion rather than inclusion. But there's no theoretical reason why BIC, you know, would have any effect more than dolutegravir, and we have to just make those assumptions, and people really need to like to stay on what they were on. So everything is essentially fair game except for Kobe.
That is, to me, the key point. So I think there's two take-home points, one of which is addressed, I think, in one of the pre-test questions, that the optimal regimen based on existing data is our second choice here, which is TAF FTC dolutegravir, based on the most recent cohort and randomized trial data. TDF3TC dolutegravir, that's fine. It's maybe not quite as good. And BIC TAF FTC, as you said, the data aren't 100% there, but when, this is the second point, when you have someone who becomes pregnant while on BIC TAF FTC, most people would say just stay the course. The challenge has always been with efavirenz, with dolutegravir, if you remember back 3 years ago where that was a no-no, is because of the neural tube closure issues, which seems to be a folate-derived mechanism and through different binding, and there's been some nice papers on how that goes, but typically as soon as you find someone who's pregnant, it's a good idea to start folate, although at 6 weeks you've missed the window for the neural tube, but that's okay. Most kids do really well, and the data are now pretty robust, so I think we hit that. And these are the guidelines from a different Dr. Gandhi that I stole this slide from.
The lesser Gandhi.
Yeah. Dr.
Good.
Gandhi the Lesser, is that what you call him? And
No, he's good.
so this is kind of summarizes what we have. I think we just more or less talked about all that. Okay, and this is the other study. I think we'll, in the interest of time, these will be in your handouts so when you get the slides. So let's go with this problem. Persistently, oh, please, Dr. Cohn.
One other issue has to do with raltegravir and those, you didn't happen to have that up there. That's an area where people are on it, get very nervous, compare or that's the other thing. So we end up, so we actually talk with the patients and inform them and really make sure that we understand what kind of, what their feelings are about things, 1 pill versus 2, how hard it is to take pills, all that kind of things. And we often continue that regimen even though we know that the levels may drop in the 3rd trimester, and we end up getting more frequent bilos, make sure they get through it. So that's a whole class of non-nukes that we do treat, but we do with caution.
Yeah.
And this person was naive,
Right.
so and of course if we do the dolutegravir and the TAF is a 2-pill regimen.
Right.
So they need to understand that.
Though
So
the one
some
good
people
thing
say
in
1
the-
pill, that's it. So
The one good thing in the HB 10084, some women got pregnant and the cabotegravir rilpivirine levels with the long-acting didn't seem to decrease in pregnancy. So I know you're talking about rilpivirine oral, but looks pretty good so far with IM.
So round of applause for Dr. Cohn, who has been here at Northwestern, right, for a while, and really focuses on women's health and has made huge contributions to literature. So thank you. Great. So persistently detectable viremia. This is a 55-year-old guy who comes in, he was diagnosed a while ago, had pretty advanced disease then, but now has got nice responses, remained in the persistently detectable range of over 50 but less than 100 every time he comes in. He's been treated with more or less everything, kind of, but now he's on dolutegravir, boosted darunavir, and 3TC, and we don't have his resistance data because he's new to us, came from somewhere else, New Mexico, let's say. And should you change therapy now? Is this antiretroviral therapy failure, in essence? So let's go ahead and vote. Here, and in honor of this song, yeah. So we went from Broadway to TV with Cheers. So the majority wouldn't change, wouldn't be prudent. Kim, what would you do?
So
You need a microphone.
No, I wouldn't.
You'd stay the course.
I would stay
Change
the
wouldn't be
course
prudent.
and repeat the viral load. One of the things that comes up a lot is just talking to the patient and saying, oh yeah, I was out of town, I missed my meds, or whatever. So I wouldn't just on one
You'd stay the
reading.
course.
I would stay the course and
Right.
just repeat one in 4 to 6 weeks.
What do we know about dolutegravir with boosted darunavir as a regimen? Monica, you want to comment on that?
Well, the Dualis study was the study in this setting that looked at patients with NRTI resistance, or another reason to put darunavir. It was a phase 2 study, but darunavir with boosted darunavir with dolutegravir, and it looked good. And then earlier we presented the DEFT study from that was presented at CROI 2023 that an NRTI resistance darunavir boosted with dolutegravir may even be superior to either dolutegravir or darunavir boosted with 2 NRTIs, though the WHO is not going to change the guidelines to do that.
Right.
So I mean, it's better to save darunavir for the future. So I would say that we know enough about it that it's a good regimen. I'm not sure why he's on 3TC.
Right, so I don't know what happened at Gerald's clinic.
Is
At
it
our
failing?
clinic, when dolutegravir got released, a lot of folks were just combining dolutegravir with boosted darunavir only, and just being real excited about that. And I was kind of nervous because way back when raltegravir got released, we had paired that with darunavir, and it didn't work so well. In fact, there was like 40% failure, and there was resistance, and I'm like, whoa, 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 tap the brakes. But it turned out to be just fine. That's why you got to do the studies. I think I'm going to move on in the interest of time to get through all this. And bottom line, I wanted to show on this slide, I don't have time to go through it, but if you start at the top with the turquoise cells that are infected in the body producing virus, the key thing is that all antiretroviral therapy does is block the infection of new cells. And the virally infected cells at the top die roughly at about a day, and they get replaced. When you give antiretroviral therapy, they're not replaced, and the viral load comes down. So the question really at the essence of this is that regimen blocking 100% of new infections? And the answer is generally yes, especially in somebody who's had a very high viral load at baseline, like his was 900,000. There's a lot more of these upper right-hand, those latently infected CD4 lymphocytes that spit out virus periodically that you're really detecting. And so if you can add to the regimen, you can give Megaheart, whatever you want to do, it's not going to change anything biologically. So I wouldn't get shook about that, especially since we know this is what he's done for the last decade or plus. I'll skip this. This is to Dr. Workowski. How do I manage a patient who has frequent UTIs? Nobody sees a patient like this, maybe except for you. And doing well on their BIC-TAF FTC, and about every 6 to 12 weeks they come in with some variation of syphilis, gonorrhea, chlamydia, or multiple of those together. And so what do you do at this point? Counsel about condoms, offer amoxicillin, doxy, or cefixime. Go ahead and vote. Without a father, got a lot farther by working a lot harder, by being a self-starter, by giving me the answer. Mic drop. Okay. Dr. Workowski, you're going to talk about this later, so we don't have to belabor it. What is your answer?
So my answer is it depends. And that's how I would approach this. And we'll get into some of the data. Does he fit the rubric in terms of the 3 studies that have been shown that have shown a reduction? Yes. So there's A1 evidence for 3 studies now that have shown that there's a reduction in the use of doxycycline 200 milligrams 24 to 72 hours after sex. that it reduces STIs. Not 100%, but yes, there's a dramatic reduction.
So this is just a preview, right?
Yes, this is just kind of a preview, and the question is, when you have to make that choice, he would check your boxes, and that's somebody that you can think about that. But you have to think about what the other implications are. I've got a case that I'm going to go over with you of somebody that I took care of that had 30 gonorrhea infections in a year.
Is that a lot?
It was for me.
Is it? Okay.
Even me.
That's one every 10 days.
And so the question is, how do I manage that person? And this was something we can talk about. So
Right.
I think the point is that it's not the panacea, is what I think you're getting at. And it is part of something in your behavioral toolbox that you can discuss with the patient. But we'll talk about the pros and cons.
Right, so what Dr. Feinstein is going to talk about this afternoon with statins is important, brand new stuff from the REPRIEVE trial. What Dr. Wachowski is going to talk to you about is this, which is also new. There's nuance, but it's pretty interesting of where it came from. So, another Wachowski question. Would you give him 4C meningococcal B vaccine? Yes, no, not sure. Take it. Chicago. No, Chicago, the original. Okay, let's see what we got here. So most would. Kim, real quick, what are your thoughts on this?
So the issue is, this all came about very quickly in terms of a retrospective study that was done in New Zealand a number of years ago when there's an outbreak of meninge B. And basically it brought down the incidence of meninge B, but it also showed there was a 30% reduction in gonococcal incidence. Since then, there's been 6 other retrospective or observational studies that have been done that have shown an association. I'll show you a poster that we presented at ECMID a couple weeks ago to show you all the data. But the bottom line is, right now there's an ongoing RCT that's going to answer this question. So there appears to be some benefit. We don't know exactly all the details, but there appears to be, from these 7 studies, that there is a benefit. And we'll answer it in this RCT that's being done throughout the country and in Thailand to try to answer this question.
So the take home to me is Neisseria species, both meningitis and gonorrhea, have obviously the same family, and so maybe immunity would be cross species. But the thing I never could understand is, why doesn't infection with gonorrhea itself be an immunostimulant enough to prevent an infection?
We don't know.
It's not, but then a vaccine is being tested that might work.
We don't know.
Yeah,
It's the bottom line.
We
So
don't know.
the bottom line is,
Okay.
we don't know. There's 95% homology between the outer membrane proteins of meninge group B. And if you guys remember that it was very hard to develop a meningococcal B vaccine, the Menactra we had kind of for a while with the 4 serotypes of Neisseria meningitidis, but group B took a while to develop, and because it was very challenging. And right now the ACIP has a permissive recommendation for vaccination for meninge B. So it's interesting, it's provocative. We don't quite know. We've submitted a paper to JID with all kind of the background evidence that's kind of under review right now to explain the kind of the whole situation and where we are. But it's very interesting, and truthfully, nothing else is working. We have an FDA-approved vaccine. We don't know anything about the duration of immunity. And as you know, you can get gonorrhea multiple times, and we have no sterilizing immunity.
Okay, so you see Dr. Feinstein's up here, and he's going to take this question. He's a cardiologist who is an antiretroviral therapy expert at this point at Northwestern. So the 62-year-old guy started on therapy years ago. Wild-type virus returns to your care after 4 years, being treated elsewhere. He's been through multiple regimens. He's now on fixed dose combination of Abacavir 3TC, dolutegravir. He's responded well. His HDL is 52. His LDA is 100, but he is a smoker, and he has no cardiac history, and his family history, let's just say, is negative. He's on atorvastatin and low-dose aspirin for reasons that I guess you could get into if you wanted to. And here he is. Besides asking him to quit smoking, would you continue his current therapy, change him to something else, or some other kind of option? Let's go ahead and vote. I made up all my mistakes. That's a great play. Dear Evan Hansen, you've been way too out of touch. Okay, let's see what we got here. So most people would change, some would continue, 25%. What are you going to recommend from a cardiologist perspective?
So I think it's and is this working, Bob? All right, cool.
Yeah.
To start off, I have to say the way I work with my infectious disease and primary care colleagues, Susan being one of them, we were talking about, several individuals we share care for. It's collaborative. I don't actually prescribe antiretrovirals for anyone, and I can potentially make recommendations based on what the data are, but the reality is you have to have an alternative.
Okay, so after the disclaimer, you've got to make
so of course, right? I mean, but that said, Mike, if there is a reasonable alternative for the person, what I'd usually say is, there's some cardiovascular risk here, certainly some unaddressed risk. LDL of 100 on atorvastatin is okay. This individual can probably get his LDL substantially lower and see a linear drop in his cardiovascular risk. He also smokes, which is probably, getting him to quit smoking is probably going to make a bigger impact on his cardiovascular risk than anything.
Ding, ding. Yes.
Including changing his antiretrovirals. And so, yes, I think, do you probably get a marginal drop in a marginal or maybe more than marginal drop in his cardiovascular risk from switching to an alternative from abacavir? Probably so, but you also, taking into account the other factors, I think addressing the other risk factors is probably going to have a larger absolute impact on his
Okay, so let me make a point with a question. So the studies have been kind of all over the map. The cohorts sort of can show up to a 1.9 relative risk increase in myocardial infarction for people who are otherwise older and at risk for cardiovascular disease, what they stay on abacavir versus being on something else. Smoking is clearly more important, a lot more important. But one of the proposed mechanisms by which abacavir can lead to increased myocardial infarction is through platelet aggregation of some way, but he's on an aspirin. That's why I did that. This isn't a real case. I made this up. But I put him on an aspirin to see what you think about the effect of aspirin through the arachidonic acid cyclooxygenase pathway to thromboxane A2.
So without going through that pathway in too much detail, you like showing off your cardiology.
No, it's actually what I did in undergrad.
So it's interesting, the data on what the optimal antiplatelet therapy will be, both for primary prevention. In this case, this is someone who hasn't actually had an MI, so that's considered primary prevention, right? Preventing cardiovascular disease before it's clinically apparent, versus secondary prevention. That's certainly a debate. But also, there are some smaller, largely semi-mechanistic studies suggesting aspirin may be a little bit less effective in people with HIV than people without HIV. I'll talk about that a little bit, and suggesting that alternatives like clopidogrel may tend to be a little bit more effective. But again, that's completely uncharted territory in terms of, aspirin for primary prevention is under extensive debate in the general population, and then when you add the complexities of potentially being a little bit less effective at inhibiting platelet aggregation in people with HIV, it's just really unknown.
So I think the common sense conclusion from all this is stopping smoking is critical if you want to do the most impact on prevention.
Get his LDL lower.
There's
too.
not a great reason to stay on abacavir, but Monica, real quick.
Yeah, I mean, just really quick, TDF, and TAF have its own issues, and renal insufficiency is a risk factor for cardiovascular disease, and I find those observational studies extremely confounded, and so I really do like the mechanistic studies, and I don't give people who are having an active MI abacavir, but I'm really really into abacavir. I think it's a very minor reason to think that we have cardiovascular disease.
And we'll also hear from you about statin use in people of a certain age and older. That is the new data.
And
so,
sorry, Mike, I'd like to say too, I agree with Monica completely on that. And that's why I guess the direct question of would you stop abacavir in older patients? No, I don't think it's a blanket comment ever. It's really, is there a particularly high risk here? Is there a clearly better alternative?
So I'm going to stay with you for this one just real quick, because this is a question on the pretest as well that you're going to get beat over the head with. But the bottom line is 41-year-old guy diagnosed 11 years ago, well treated, now on dolutegravir, 3TC fixed dose, undetectable virus, CD4 610, everything else is kind of normal. LDL is 155. If you do the cardiovascular risk estimate, you put on the numbers, it comes out to an estimate of 2.5% over the next 10 years, which is generally considered pretty low. So with all that craziness in this 41-year-old guy, would you start a statin now? Yes, no, not sure? Let's vote. Schmigadoon. So I really like the show. If you're a big fan of Broadway musicals, it's great because you get to see what Cinco Paul did to incorporate style of music from old musicals into new songs. So, all right. So I already see a change from the pre-test, and probably by the end of the day, you'll be at 100% yes. I'm not going to go into discussion for time, but I'm just prepping everybody to look to you for that answer, but the answer yes is correct based on the Reprieve study, all things being considered with a little this. So you get to see what that is later today. There it is. I'll let you go through. All right. So last two questions quickly are about COVID and HIV. So 65-year-old guy, low-grade fever, cough, headache, and sore throat for 2 days. Rapid test is positive for COVID. Influenza test at the clinic is negative. Less than 20 copies. Is a smoker. Dolutegravir, lamivudine, rosuvastatin, a few other drugs, including rivaroxaban, etc. And oxygen saturations, about 94 to 95% of marriage, 1 to 2 days into illness. Would you initiate which of these drugs in the current era, like today? Let's go ahead and vote. Or picture show. Okay, got it. First it sounded like Hedwig and the Angry Inch.
No. This is a moment, everyone. Mike didn't know one of the show tunes.
Okay. It's because I've never seen it. Yeah, I know. Okay, here we go. So, what do you think about this? Anybody?
Well, at this, we have somebody with, we call it mild to moderate COVID, and our goals of care thus far, preventing him from being hospitalized or dying from it. It all depends on the age of the person. This is the largest maybe risk factor here. I don't recall everything about that person, and that's maybe a little more. There you go. So you have a smoker, and so all these things to tell they are 65 or more. Probably the biggest risk factor for progression is age, HIV or not. So it's important to consider treatment in this person. Now, the caveats here are that the most efficacious drug for that endpoint, preventing hospitalization or death, is nirmatrelvir, ritonavir, and the concerns are mostly in drug-drug interactions. So we have this person on rivaroxaban and vardenafil, two possibilities of interaction are here. Now, we have possibilities of considering interruption of these drugs if safe to do so. I imagine vardenafil is erectile dysfunction, not pulmonary hypertension, and
Yeah, so just in the interest of time, that was the point of the question, was that there are some of these drugs, carbamazepam in particular, to some degree rivaroxaban, rosuvastatin to a degree, you could just hold that. But the drug-drug interactions are really numerous because of the CYP3A4 inhibition with ritonavir that everybody in this room knows well. Go to the Liverpool drug interaction COVID thing, and it just flies you through it. But I don't know that we can get away with Paxlovid here. What I would do in a patient like this, all the other ones, the monoclonals don't work against the Omicron, and I think in this case, since I'm worried about this guy, he's got a little bit of hypoxemia already. It's day 2. If you're going to give an antiviral, you need to give it right now. He's a smoker. I would probably go for outpatient remdesivir, which works incredibly well, and it's logistically tough. But yeah, Connie.
That's what I was going to say, is that
Just keep talking.
keep going.
Or use rabies.
Use rabies. Although not directly compared in clinical trials, the remdesivir trial with 3 days of outpatient infusion had dramatic reductions in hospitalization and mortality and disease severity. And even with inpatient COVID therapy with remdesivir, with the stage of disease he has, it virtually stops disease progression.
So I had several points. We've run out of time, so I'll just make them quickly. But the drug interactions are probably prohibitive for Paxlovid here. Molnupiravir could work, but not nearly as well as remdesivir. Remdesivir has been slotted because of its intravenous requirement to late, like 7-day, 10-day, when they get admitted. That's too late for an antiviral. I mean, it works a little bit. It's amazing. It does anything. It works great when given early, like all antivirals. We've learned treat early, treat hard. We learned that in HIV. We need to do it here, and it will save lives. So none of the monoclonals work against the new variants. This now that we're at XBB 1.16, which is a pretty horrible virus in terms of transmission, as Dr. Volberning found out. And I'm going to skip this last question in the interest of time. It's a classic tough case that you might reach for lenacapavir or maybe some of the other drugs like FOS.
Mike, I just think the other thing to bring up is that the logistics of doing that are just very challenging now with all our staffing shortages.
Sure.
And even, it's just really hard. So I would agree with that in premise. I'm just saying the trying to get it done in a quick way is very challenging.
So what I would suggest, I agree, what we've done at our place, although you can't maybe implement it, but we did a lot of monoclonal antibody and we used the infusion center. So we just turned them over to remdesivir, not saying it's easy and we don't abuse it, but sliding them into the infusion center in a special isolated area where they're not infecting the patients with malignancies who are getting infusions, that has worked for us, but we don't abuse it. So finally, I'll just finish up here. Antiretroviral therapy should be initiated in general with a strand transfer integrase inhibitor as close to the time of diagnosis. Weight gain is associated with, especially with NSTs and TAF. Dolutegravir and TAF are drugs of choice in a regimen in pregnant women and give folate. Simplification is doable, but it depends on the case. You're going to hear more about doxycycline for the right type of patient and frequent STIs, and watch for drug-drug interactions with SARS-CoV-2, and that wraps us up. I want to thank the panel for a wonderful discussion. Everybody sort of chimed in with their expertise. It was great. It made my job easy. Thank you for your attention. turn it back over to Dr. Benson. Thank you, guys.
So we're going to move on with our program and have some, turn the page here. So our next discussion this morning will be given by Dr. Rafi Landovitz, who is a professor of medicine at University of California, Los Angeles. Rafi is one of our superstars in the investigation of preventive therapy for HIV, has led almost all of the major clinical trials, most recently presented on preventive therapy, and he is going to talk to us about latest updates on HIV prevention. Rafi?
Thanks, Dr. Benson. Thanks, everybody, for sticking with us this morning. It's always really hazardous to stand between people and lunch, so I'm going to try and be pithy here. So these are my disclosures. What we're going to talk about today is we're going to talk about oral PrEP to start with, and what I think is the most challenging current clinical decision-making sort of crossroads that clinicians are facing, which is what to use for oral prevention if that's what someone is interested in pursuing, and what the decisional balances are. I'm going to talk a little bit about some of the new CDC testing algorithms, which came out in the 2021 guidelines, which are pretty controversial. And, you know, I love stirring the pot about this, so this will be really fun because I'd love to hear what you guys think. And then we're going to talk about injectable PrEP and some of the agents that are in advanced clinical development that hopefully will move the field forward. So first of all, our first agent that was FDA approved for HIV pre-exposure prophylaxis, TDF-FTC, the artist formerly known as Truvada, now available generically. Just in case anybody does have access to TDF-3TC, that's generally considered to be interchangeable. So if that's the only thing you have access to, that's completely fine to use. Any of you have heard me talk on this topic before know this is one of my favorite slides on the planet, because if anybody just puts up lists of clinical trial results and their levels of efficacy, you all will be on your Instagram and your email in 30 seconds and not paying any attention. So I created this little puppy actually in 2015 because I grew up in the Northeast of the US, and I don't know if this is a thing in Chicago, so you guys can tell me, but in the Northeast around the holiday time, churches, synagogues, bazaars, mosques, they do philanthropic fundraising, and outside of the place of worship, they put a big thermometer, and then they fill up that thermometer with some sort of color as they're reaching their fundraising goals. That's the concept here, right? So each figure is the sex at birth of the population that was studied. How full the figure is the point estimate of the preventive efficacy with regard to HIV incidence in each trial. So what you can see here is there's a wide range of outcomes, including some ones where there are some women standing in puddles. We'll come back to that in just a second. But the variety of clinical trial results when TDF-FTC daily PrEP was being studied caused a tremendous amount of consternation and confusion among providers and among consumers. And why does it seem to work in cis men and trans women, but not in cis women? But, oh, look, it can work in cis women, and what's going on? And we'll get to what the punchline is in just a second. But I want to come to the lower left corner of this slide, which is the VOICE study, which was a study that in follow-up to the Partners PrEP study in the upper right was supposed to be the confirmatory study for cisgender women whose predominant sexual route of exposure to HIV is vaginal intercourse. This was supposed to be the confirmatory study for that. And what you can see here is there was actually a trend, the point estimate was towards harm. There was increased HIV acquisition among the women who were randomized to active TDF alone or TDF with FTC. And that really turned everybody on their head. And I really struggled when I made this slide about how do you present a negative point estimate. Do I turn the character on its head? Do I put a shadow in back of it and fill up the shadow? Or do I put a puddle under it? And I asked my division chief at the time, Judy Courier, who if any of you know her, she's incredible. I said, Judy, what do I do? She said, definitely not the puddle. The reason she said that is when I first drafted this slide, I used red. I think it works okay in blue. I will tell you, I keep a copy of this slide with it in yellow at home just because it makes me giggle. But regardless, what's happening in the lower right corner here, the little guy with the French beret who sort of looks like a psychotic mime from jail, what that is it's a different way of dosing. It's not daily dosing of TDF, FTC. That used to be called disco dosing. We now call it 2-1-1 or on-demand dosing. It actually works. We'll talk about that in just a second. But the punchline of all of these studies we now have come to understand is this works both for rectal exposures and vaginal exposures, and that's really the essential difference about the way we need to think about PrEP biomedical prevention efficacy, right? Because the drug concentrates differently in rectal tissue as opposed to cervical vaginal tissue in the female genital tract. And what we know is the TDF component specifically concentrates much better in the rectal compartment than the cervical vaginal tissue. And we think that that leads to these observed trial results, not because it can't work in the vaginal compartment, but because it's less forgiving to missed doses. You need to be more, if you will, religious about the daily dosing to get high levels of protective efficacy in the cervicovaginal compartment as compared to the rectal compartment. What we believe to be true is if taken daily as prescribed, TDF efficacy for rectal exposures is north of 99%, and it's probably somewhere in that ballpark too for vaginal exposures. The data, and this is all sort of post hoc analysis, this is from analysis from Deborah Donnell that was published in JADES in 2014 from the Partners PrEP study. They only did plasma measurement of concentrations, which is not a particularly good biomarker of long-term adherence. It's just a short-term adherence marker, suggested about 94%. But high levels of protection is attainable. We think you need 6 or 7 doses per week. There's some newer data that suggests maybe you can get some pretty high levels of protective efficacy with less frequent dosing in the vagina, but I would not recommend it, and that really isn't where the field is yet. But you can be down to as few as 4 doses per week and still have high levels of rectal protection, which is really important to know as we talk about other ways you could potentially take that drug. So here's the punchline, right? Something that you all know from your clinical practices: if you don't take a drug, it doesn't work. You can't expect it to work. And if you looked at the correlate of the protective efficacy with biomarkers of adherence to the drug in these early PrEP studies, you can see a fairly close linear correlation. You're wondering why that red dot is bouncing there. It's not just to make sure you're still awake. It's that they only used pill counts. There weren't actually biomarkers in that particular study, proud, and so we don't actually know what the concentrations were. But let's talk about this disco dosing for a second. When this first was being described as something people were trying in the field, a lot of preventionists said, don't do that. That's not going to be a good idea. And what we're talking about is if somebody is planning to have sex, let's make this up, today's Friday, this weekend, I don't know, tomorrow, right? Then the idea is people were sandwiching that planned sexual activity with TDF FTC dosing. It was called disco dosing because back in the day, people actually went to discos, right? I don't think that people call it that anymore, but you get the concept. But so Jean-Michel Molina, who's at the University of Paris, did this really interesting study because he said, hold on, maybe it's not so crazy. The other studies seem to have shown that 4 or more doses per week confer high levels of rectal protection. Mightn't it be true then that this sandwiching of sexual activity around these doses might work? And he did the Hypergay study in France and Quebec. And the dosing is sort of what's shown on this little schematic. If there's planned activity that's going to happen on a certain day, taking a double dose of TDF FTC 2 to 24 hours before that planned sexual activity, and then following that up with a single dose of TDF FTC 24 hours after the double dose, and then a third and final dose of TDF FTC 24 hours after that second dose, again, sandwiching the sexual activity, was studied in a TDF FTC active versus placebo study. Punchline, 86% reduction in HIV incidence in the active versus the control arms of that study. Importantly, however, this really is designed for people who are having infrequent sexual exposures, because the sort of asterisk on this dosing regimen is if the planned sexual activity from Wednesday also happens again on Thursday, maybe on Friday, maybe twice on Friday, and then again on Sunday, let's say, what the instruction is that you keep doing the single doses every 24 hours until 48 hours, so 2 doses, 2 days after the last sexual activity. So 2-1-1, which is what this sort of regimen has come to be called, devolves very quickly into 2-1-1-1-1-1-1-1-1-1, which is daily dosing, right? So this really is for people who are having sexual activity on average about once a week or less frequently. It doesn't really make sense to sort of attempt to dose it in this way in other contexts because it turns into daily dosing. But it does work. Now, a lot of people are uncomfortable with trying to prescribe this because it's not FDA approved for this pattern of use, and the CDC has actually stopped short of recommending it. They acknowledge that it exists and there's data to support it, but they've not come out and recommended it. Interestingly, the San Francisco Department of Public Health and the New York Department of Mental Health and Hygiene are the 2 jurisdictions that I'm aware of that have come out with a recommendation for the use of this. The IAS-USA guidelines have been recommending it since 2020, so you are on good recommendation standard if you decide to prescribe it in this way. The populations that this should be used for, this was only studied in cis men and trans women who have sex with men. You probably can generalize that to all males, but we can talk about that later. Do not try this for vaginal exposures. There are no data. Interestingly, when that Ipergay study went into an open label extension that Dr. Badimo already mentioned, called Prevenir, on the bottom of the table, this sort of second row there, you can see that if you give people a choice, this was done just in France, not Quebec, of either daily dosing of TDF-FTC or this 2-1-1 on-demand dosing. It was about a 50-50 wash. People chose one versus the other, and the HIV incidence was really low in both arms. So in real-world settings, it does work. Some people always say, but how do you prescribe it? It's actually prescribed the same way you would prescribe daily oral TDF-FTC. You give people no more than 3 months at a time because, really, if they're having any more frequent sex than once a week, it's going to devolve into daily dosing. So you sort of prescribe and monitor it as if it were going to be used daily, and you just give people some instructions. San Francisco Department of Public Health has an instruction sheet for patients that you can print out, use online, and give people some ideas about how to dose it. But you bring them in every 3 months for HIV testing and STI testing, the same way you would if it was daily dosing. So let's move now to what I like to call PrEP 2.0. TDF-FTC PrEP was PrEP 1.0. We now have a number of other studies that suggest activity for a number of other agents. Let's first talk about TAF-FTC, the artist formerly and currently known as Descovy. Right? We know from the HIV treatment literature that this is a safer from a bone and renal standpoint, but equally efficacious version of TDF-FTC. Right? Yes, it has these other complications that Dr. Gandhi and Dr. Badimo and others were referencing that we'll come to just in a second in terms of metabolic effects and weight changes. We'll come to that. But the major question that was asked in the prevention space was, did this work as well or better than TDF-FTC when used daily for HIV prevention? So there's one study that really gives us information about this that we have the results of. This was done in cis men and trans women who have sex with men. It was called the Discover. It was a Gilead-sponsored study that head-to-head compared daily oral TDF-FTC to daily oral TAF-FTC. And I'll get right to the punchline. These were the efficacy results. Basically, there were very few incident HIV infections in either arm. Statistically, this was a non-inferiority result, so you cannot say that one was superior to the other in this trial. They worked essentially equally well. The absolute number of incident HIV infections was lower in the TAF-FTC arm, the TDF-FTC arm, and very sensitive markers of renal function and DEXA measurements of bone density all favored the TAF-FTC arm over the TDF-FTC arm. So from that, there is a general perception and A lot of advertising seems to want people to think that we know for a fact that it is a safer option. I don't know that we really know that. It is FDA approved down to a creatinine clearance of 30, whereas TDF-FTC stops at 60. So there is that to think about. And certainly if you have somebody with a history of non-traumatic fractures or known osteoporosis, it might be a reasonable choice. But I've sort of been hearing that a lot of providers are en masse, wholesale, switching all of their patients who are having rectal exposures from TDF-FTC to TAF-FTC, and I don't know that that's warranted. This is one of my favorite infographics on the planet. It was made by Julia Marcus, who at the time was at the Kaiser Foundation in Northern California. She's now at Harvard, but this is publicly available. She posted it on Twitter, so you can find it there. I have printed this out, I laminate it, and I keep this in my clinic when I see PrEP patients, particularly ones who are coming in saying, I saw an ad for TAF-FTC, or all my friends are on TAF-FTC. Shouldn't I be on TAF-FTC? And I think it's really important to know a couple of things. First of all, TAF-FTC is a smaller pill. So for anyone, particularly adolescents, where that's a big concern, that may be something that would push you one way or the other. We only have data for TAF-FTC in cis men and trans women who have sex with men. We do not have data for any heterosexual encounters, and we do not have injection drug information. We have all of those data for TDF-FTC, as you'll see on the left side of the slide. The efficacy is essentially the same. So let's take that off the table. One is not more effective than the other, full stop. In terms of safety, 4 domains. There are 4 domains you need to think about. First of all, creatinine clearance, right? We know that in terms of changes in estimated GFR, TDF-FTC has associated with small decreases, TAF-FTC associated with small increases. So somebody who is at pre-PrEP initiation risk of renal toxicity, either they have a creatinine clearance already less than 60, Monica Gandhi has done, who's maybe in the back, maybe she's sort of tired of this talk and has heard it, oh, there she is, has done some really elegant work that suggests that the population who's more at risk for major drops in creatinine clearance with TDF-FTC is starting under 90. So that's somebody that you might want to think about it, somebody who's got other risk factors for having renal disease, hypertension, diabetes, other comorbid conditions. You may want to think about that in the decisional balance. In terms of DEXA, modest changes in the opposite direction in the TAF-FTC versus the TDF-FTC. No difference in clinical fractures. That was short-term follow-up, though. I don't know that you would have expected to see differences in clinical fractures, but it is something to keep an eye on. One thing to remember about the bone mineral density losses that are seen on DEXA with TDF-FTC is they resolve 6 months after stopping that drug, at least in adults. The one population where that doesn't appear to be true are adolescents under age 25 who are still accruing bone mass. So that may be something that you want to think about, particularly if you have an adolescent who either has a family history or a personal history of osteoporosis or non-traumatic fractures. And then there are these other issues. TAF is associated with weight gain. TDF-FTC is associated with weight loss. We know this. TDF-FTC has an anorectic effect, particularly in the first year. It's a little unclear if that's due to the sort of 2 to 4 week gastrointestinal side effects that people experience when they're starting TDF-FTC, or if there's something more profound mechanistically that's going on that causes that weight loss effect, but it does appear to be a real effect. So there is that difference, and then there are modest differences in what happens to your LDL cholesterol on TAF-FTC compared to TDF-FTC, where on TAF-FTC the LDL cholesterol goes up, on TDF-FTC it goes down. There's some debate about whether or not that's TDF just being suppressive and TAF-FTC having just modest effects, but for somebody who you're already fighting to control their lipids, it is something to consider. So those are the 4 domains I always talk about, and I practice on the west side of Los Angeles, so you can imagine what people's reaction are when I tell them, well, you might gain weight. Okay. Let's move on to long-acting injectable cabotegravir, which is sort of the new shiny kid on the block, right? FDA approved in December of 2021, right? Its brand name is Apretude, but we're going to call it long-acting cabotegravir, right? We've already talked about it a lot in the context of treatment as this injectable regimen, Cabenuva, with long-acting rilpivirine in combination. right? So 2 registrational trials led to the US FDA and now a bunch of non-US regulatory approvals as well, HPTN 083 and 084. The only really important difference between the trials was the population and the geography. 083 was done in cisgender men and transgender women who have sex with men at 43 sites in 7 countries, including the US, Peru, Brazil, Argentina, South Africa, Thailand, Vietnam. And 084 was done in cisgender women in 7 countries in southern and eastern Africa. All of them had the same general structure. HIV negative people who were at elevated risk for HIV acquisition, generally in good health, ages 18 and up. 084 capped at age 45. 083 had no cap on the age. Everybody got 5 weeks of an oral lead-in to establish the tolerability before giving the long-acting injectable. Footnote, now that it's FDA approved, that oral lead-in is optional, but that's how it was studied in these registrational trials. And then a 3-year direct oral to injectable comparison, and the comparator was daily oral TDF-FTC. And then out of this concern that this very long-acting drug stayed in your system for a year to 2 years or more after your last injection at declining concentrations, what would happen if somebody were exposed to HIV during that period where the cabotegravir is washing out of the body? So presumably it's not at protective levels anymore, but you're exposed, but there's drugs still there. Would you get integrase-resistant virus? And was that going to then make your subsequent treatment more challenging? And so that washout period was covered with a year of daily oral TDF-FTC. We called it covering the tail, or step 3 in this clinical trial. Does that rationale make sense to people? Silence equals definitely yes. Okay, good. Okay, so here are the clinical trial results sort of broken down. Long story short, both the blinded trial results on the left side of each of these slides, both studies were stopped early for superiority of the long-acting injectable PrEP agent compared to daily oral TDF-FTC, and then continued in an open label extension, which is persisting at this point. This year 1 unblinded analysis that's next to the blinded, everyone was still on their original randomized treatment regimen. They weren't given the option yet to have switched to either product. So this is essentially an extension of the blinded data. Long story very short, in the 083 study, 66% reduction in incident HIV in the injectable product compared to the oral. For the cisgender women, 89% reduction in incident HIV infections, which if you think about it, as impressive as 66% is for the cis men and trans women trial, a 90% reduction in HIV incidence among cisgender women where it's been really challenging to find a biomedical prevention product that is sort of acceptable and sort of implementable. I mean, it's sort of staggering how successful that study was, I think. So I think that's a mind-blowing result. So right now, the study is in an ongoing extension where a couple of things happened. Everybody was offered choice of either product. The oral lead-in for people who were starting the cabotegravir was made optional. And there was an opportunity to study different HIV testing algorithms. Wait, what? Okay, I'm going to come back to that in just a second. At CROI, we did present some bone mineral density data for cabotegravir compared to TDF-FTC, and it kind of looks a lot like the TAF-FTC, TDF-FTC comparison, to be honest, right? We know what happens to TDF-FTC, bone mineral density at sentinel sites goes down. With cabotegravir, it seems to go up. So again, if you have somebody with traumatic fractures, that's reassuring. Does it mean that that's a reason to switch? Not necessarily. Okay, testing. So one of the most controversial things that happened in the CDC guidelines when they came out in 2021 was a recommendation that viral load, or RNA testing, be integrated into routine monitoring for breakthrough HIV infections with somebody on PrEP. And the recommendation applies not only to long-acting cabotegravir, that I will explain to you the rationale for that recommendation with long-acting cabotegravir in just a second, but also for oral tenofovir-based PrEP monitoring. And I have heard from so many people that that is not something that is implementable in their settings. It's going to blow costs out of the water, and people don't understand why that's necessary. It's not like we've had a public health scourge of acute HIV infections with just regular antigen or antibody-based monitoring of TDF-FTC PrEP. So when we get to the question and answer period, would love to hear your thoughts on that. I'm happy to share with you mine. But when using long-acting injectable cabotegravir, here's an example of one of the CAB PrEP failures that we had in the HPTN 083 study. What you're looking at here on the x-axis is the weeks from enrollment on the study. What the y-axis is the cabotegravir blood concentrations. Okay, so the orange circles are the cabotegravir concentrations over time. The green vertical lines are when people got cabotegravir injections, right? So you got a month of daily oral dosing, right? So nothing before they started, that makes sense. Then they're taking their oral dosing. We measured it 2 and 4 weeks in, and that top line are way above the monkey model correlates of rectal protection. So that top line, if you're sort of there above, you should be okay based on the animal models. Okay, so good levels. And then you start your injections. There is that little dip between the first and second injection. We'll come back to that. And then injections continue. What you see is out at about week 38 out there, that blue line, the site testing turns positive. They were just doing antigen, antibody, and rapid testing at the visit. So they found the HIV infection there. Luckily, we stored specimens. We stored plasma from every visit in this study. So we went back at the Johns Hopkins Central Laboratory, and we went back and did all sorts of sensitive testing on those stored specimens. You actually can find evidence of the HIV infection where that red line is. And what you find is that viral load was the most sensitive way to detect it. It was 860 when it was first detected, but the testing at the site didn't flag it. So they went on administering the intramuscular cabotegravir. And what you can see from the sort of sensitive low-level genotyping that we did that's listed way at the top of this slide is when this virus first breaks through, it's wild type with regard to the integrase gene. There was some transmitted K103N, but that had nothing to do with the PrEP breakthrough. It just was, right? But by the time the site found the infection, it had integrase resistance. So the question becomes, you might say, well, so what? You found it earlier. Well, you might have been able to avoid integrase resistance if you found it earlier. So that was the rationale for why the FDA package insert and the CDC guidelines for use of CAB PrEP recommends that you use a viral load to monitor for PrEP breakthrough on cabotegravir, particularly because, like I mentioned when we were on the panel talking about this phenomenon of there's a price to pay when you go to injectable antiretroviral treatment, that there's a small but real rate of virologic failure even with on-time injections. That's true with CAB PrEP also, right? It's a case-level report when daily oral TDF FTC fails, right? We talk about it. It gets presented at conferences, right? Not true with cabotegravir PrEP. There's somebody in this audience who I was speaking to earlier who has a clinical patient who was on CAB PrEP and it failed despite on-time injections. It got presented at CROI this past year. It happens. It's not going to be as rare, I don't think, as with daily oral PrEP. So you have to have a high index of suspicion when your tests turn positive. The other thing is people are like, oh, there were no signs or symptoms of acute HIV infection when they, so I didn't send an RNA or a viral load. CAB PrEP failure doesn't look like conventional HIV infection. Our laboratory person from the 083 study, Sue Eshelman, has given it a name. She's calling it Levi syndrome. It stands for long-acting early viral inhibition. Not the cutest name in the world, but the point is it's different from our usual clinical conception of what it looks like, which is a mononucleosis-like syndrome, lymphadenopathy, oral sores, fevers, all this clinically silent, clinically protean. You may see nothing, but you have these low smoldering levels of viremia. So you have to have a high index of suspicion. Okay, so people say to me, okay, Cabotegravir was superior to daily oral TDF-FTC. Shouldn't I switch all my patients to cabotegravir? We can have a great conversation about how difficult cabotegravir PrEP is to actually use, just as hard, if not harder, than using Cabenuva. But no, the best PrEP is the PrEP that a person will adhere to, full stop. There is no obligation to switch everybody to injectable PrEP. How quickly do you get protection? We don't know. It's somewhere probably between 2 and 7 days based on PK, but that's my best guess. We actually don't have clinical data. And how do you salvage those failures, particularly because commercial genotypes won't let you get information if your viral load is less than 500 in most cases, right? So how are you going to know if there's low-level integrase resistance? Great question. My recommendation is don't try and salvage it with dolutegravir or bictegravir. Salvage it with a boosted PI or an NNRTI if you can exonerate NNRTI resistance. And, do we have the will to figure out how to use this drug? I'm not so sure right now, so would love to hear your thoughts on that. Okay, super quickly in our last 1 minute together, what's the future of prevention that I'm excited about? Rings, vaginal rings. Really exciting. There was a non-nuke-based vaginal ring that had dapivirine in it, somewhere between 30 and 50% protection. If you actually look at the open label and observational studies, maybe as high as 70% for vaginal protection. It is not going to get approved in the US. It was withdrawn from consideration, but rings are not dead. People are pursuing it, not just with antivirals for PrEP, but also for combined HIV prevention and hormonal contraception, which could be very attractive. So this isn't going to be the end of what we hear about that. Connie Benson promised you that I was going to show you the slide, so Connie, here it is. Lenacapavir, you all know, is approved as part of heavily treatment-experienced HIV treatment as a every 6-month subcutaneous injection. It's in phase 3 clinical trials for PrEP. You do have to do a 2-day loading dose with oral right when you start. And it is administered subcutaneously every 6 months. And if any of you are participating in these studies, I'd love to hear your experience, because where we're doing it in LA, I hear that it's actually quite painful, these subcutaneous injections. And so tolerability, I'm a little concerned about, and I would love to hear what people think. The advantage, of course, is assuming it's safe and effective, is if you break through and have resistance, it's not part of first-line treatment, so you haven't compromised your treatment options, and every 6 months is obviously extremely attractive. People are really jazzed about MABs, right? This-a-mab, that-a-mab, tigalexamab, I can't even pronounce a mab, right? I mean, and so, of course, it won't surprise you that there are MABs for HIV prevention. One was in a phase 2b/3 study. It did not work. Now they're looking at if 1 is good, maybe 2 is better, maybe 3 is best, maybe 4, who knows? So there are combinations of MABs now being tested for prevention. Will they work? Your guess is as good as mine. Didn't seem to work so well in the COVID arena, but where people are still optimistic about HIV. I think this was already mentioned at CROI, we're still 40 years away from 40 years into the HIV epidemic. We're just as far away from an HIV vaccine, unfortunately, as we were 30 or 40 years ago. The most recent vaccine trial, unfortunately, was a complete wash called Mosaico. So we do need these PrEP agents, and we need new ones. These were the HIV survival curves with the probability of HIV infection in the active versus the placebo arm of this vaccine trial. Everybody was incredibly disappointed in this result, and when Susan Bookbinder presented it at CROI this year, like the whole temperature in the room went down 20 degrees with the presentation of these data. Dr. Benson and Dr. Badimo already mentioned islatravir having sort of been taken out of consideration in the PrEP space because of this lymphocyte toxicity. I honestly was the most excited about this product compared to all the others in development because it was going to be a once-monthly pill. And at first I was not so convinced that that was going to be really attractive, but then someone said to me, and this is very true for me, is don't you remember to give your dog flea medicine on the first of every month? I do. And so this, there are a number of monthly things that people do. They pay their rent. They, give their dog the flea medicine that they could tie this to and anchor this to. So I thought this was going to be very exciting. It still hasn't been taken completely off the table in terms of an implant, so that may not be dead. And Dr. Benson referenced that they have a follow-on compound. It's got an incredibly sexy name. You're going to love it. MK8527. Don't you love that? Yeah, so that's a follow-on compound in the same class that actually is already in human trials. They don't think it's going to have the same lymphocyte toxicity and could be dosed on the same once monthly schedule for PrEP, so stay tuned for potentially more about that. This once monthly oral tablet is not completely dead. So where are we? 40 years into the pandemic, still have a lot to be done. We don't seem to be that close to a vaccine, so we need these agents. A single agent is not going to get us out of this. We need options, we need choices. And we're 10 years into the approval of TDF-FTC. We still haven't figured out how to get these PrEP agents to people who need them, and that's really frustrating. And we really have to figure out what people want and where they want to get these services. So I'll stop there. Happy to answer any questions, and thanks for dealing with me 5 minutes over.
So, as promised, a tour de force of prevention. Before we move on to Q&A, I just want to do a shout out. We have a driver's license here that was dropped somewhere in the back. James Lagusic, if you want your driver's license back, come and get it. If you've left already, sorry. Okay, first question. This is not PrEP, but PEP. So you didn't talk too much about that, but could we use Biktarvy for PEP instead of Truvada and Tivicay?
Yeah, it's a great question. You know, Ken Mayer from Fenway Institute has published a case series on safety and course completion of post-exposure prophylaxis with Biktarvy. It seems like it's a reasonable thing to do. There's no reason it shouldn't work. I'll be honest, the last couple of times I have written for PEP, a lot of local pharmacies have not been excited about accessing it in a timely way for PEP, and that's been really frustrating. But I've also been challenged in actually trying to find dolutegravir by itself to use as PEP commercially. So I think you get into somebody whatever 3-drug regimen you can get your hands on that's of that tenofovir with 3TC or FTC and an integrase inhibitor into someone as quickly as possible after the exposure. I think that's reasonable.
Great. While I'm waiting for other questions, maybe that I just can't read this iPad or this pad here, but we'll try this one. In the era of U equals U, what's the marginal additional benefit of PrEP for monogamous discordant couples with undetectable viral load?
Great question. Just to make sure we're all on the same page, we all know U equals U is sort of how we've devolved this concept. If somebody with HIV is on treatment and undetectable, they are non-infectious sexually, right? Full stop, period, end of sentence. That is not debatable. That is not a question. There have been exactly 0 examples of that not being true in the medical literature. So that's U equals U. So if you have somebody who is truly in a monogamous relationship, and one person is living with HIV and is on treatment as undetectable, and the other does not have HIV, there is no utility of adding PrEP. The million-dollar question is what does monogamous mean and to whom, right? Is monogamous monogamous or is it monogamish? Right? Because, I mean, we all have patients and situations where someone finds out that what they thought was a monogamous relationship actually wasn't, at least on the part of one person in the relationship. And the way that manifests is sometimes with an STI, and all too frequently that manifests as an HIV infection. So if someone comes to you and says, we're in a monogamous relationship and my partner's positive, but they're on treatment and they're undetectable, and they're not forthcoming about having partners outside of that dyadal relationship, I assume that there's something they're not telling me if I explain U equals U and they still want to go on PrEP. So I will not refuse to provide PrEP in that context, but I will make sure people understand U equals U and what it means in the context of that partnership.
Okay, I'm going to ask a couple of my own questions while we give the audience additional time for theirs. So one of the most difficult populations for us to deal with, at least in our clinical group, are adolescents. So what is your favorite approach to PrEP for the younger adolescent group? And as we all know, the NIH considers you an adolescent up until the age of 24. So I'm not talking about the 24-year-old. I'm talking about the 14, 16, 18-year-old group.
Yeah, great question. And, that's the population where incidence is extraordinarily high and challenges to adherence are also extraordinarily high. The ATN 113 study looked at 15 to 17-year-olds and found not only was adherence poor, it went from poor to abysmal over 48 weeks, and the incidence in that population, despite trying to administer PrEP, was 6.3 per 100 person years, which is staggering. So it's a huge challenge. I think what's clear is adolescents and youth need even more support and more frequent contact than we're used to providing. I think trying to do things remotely and not having them have some contact with your clinic at regular intervals, maybe even more frequently than 3 monthly, is probably something that needs to be considered. Text messaging and social media contact seems to be critical to maintain engagement. And we don't know yet if some of these longer acting agents are going to solve some of these problems, because you still have to show up for a visit to get the injection. There was an adolescent bridging study that was supposed to accompany HPTN 083. It was led by Sybil Hosek, who's at Kroger here in Chicago, and they were unable to enroll the study. They only got 9 people on the study. So that's all the data we have in adolescents. So we're now that there's regulatory approvals, we're going to have to get some real clinical experience with how to do this. I have heard that the small size of the TAF FTC tablet is a big deal for a lot of adolescents. So that's a differentiating factor that seems to rise to the top even more for youth and adolescents. But if anyone else has additional experience, would love to hear it. I don't think we know the perfect menu or combination of services yet, but you need a commitment to figuring it out if you're going to work in those populations.
Hey, great talk, Rafi. So what was the rationale for the CDC saying to monitor viral loads in people that were on oral PrEP?
So thanks, Doug. So the question is, right, what led the CDC to make this recommendation for viral load monitoring with tenofovir-based oral PrEP? So if you look at the references that accompany that guidelines, it references 2 things. It references HPTN 083, which was the study that I led, and also references a study in Thailand that showed that older generation antibody tests were actually more sensitive at detecting acute or primary HIV infection than our later or modern generation antigen antibody tests. So they were very uncomfortable with the ability of modern 4th generation or 5th generation antigen antibody tests to detect acute or early HIV infection. So that's one thing. The HPTN 083 data, in my opinion, and the CDC team knows that I feel this way, and we're going to agree to disagree, is I think they're misinterpreting the HPTN 083 data. There was administrative bias that led to a handful of people with hyperacute HIV infection on our TDF FTC arm being found 4 weeks after, on retrospective testing, they were in the very early throes of acute infection. And it was on that basis that the recommendation was made. Do I think that that's necessary? I don't. Do I do it in my clinic? I don't. Because I ask, what are the consequences of missing it, even for a month if someone's hyperacute. Worst case scenario, you get K65N M184V virus, right? We know from Nadia and VCEN and a number of other studies that dolutegravir-based ART or bictegravir-based ART is probably going to work just fine in that setting.
And another question from the audience. Can you speak to the data or lack of data in what you talk about to patients who have chronic low-level viremia and get significant anxiety because they don't fit the U=U mold and feel a degree of stigma or guilt about their partners having to be on continuous PrEP?
Yeah, great question. So if you actually look at the studies on which the concept of U=U are based, less than 200 copies was the definition of undetectable in those studies. If you actually go back to the Rakai cohort in Uganda, there actually seem to be no transmissions below 1,000 copies, but I think 200 is probably the right metric. So as long as somebody is under 200, you can speak with confidence that the principles of U=U still hold.
Okay, and then apropos of our earlier discussion about adolescents, is there an age requirement for injectable PrEP?
Also, great question. Happily, none of the FDA-approved PrEP agents have a age floor to their prescription currently. It's a weight-based floor. So as long as somebody is 35 kilograms or 77 pounds or greater, the FDA approval applies.
And what are your thoughts on bridging with oral PrEP when initiating long-acting cabotegravir, and for how long based on when PK levels are achieved?
So that's an incredibly insightful and great question. And the answer is nobody knows and there are no recommendations. However, if you look at my PK estimate that after the first injection, time to protection is probably somewhere between 2 and 7 days. You could say from that, it would not be unreasonable to do some sort of bridging or overlap with the first week after the first injection. Those of you who were paying attention to that one clinical failure case that I put up there might have noticed that there was this nadir between the first and second injections of the concentrations. So some people have asked, should it actually be an even longer period of overlap of a month? So the entire time period between that first and second injection. And I didn't get to talk about this, but this whole concern about integrase resistance during the tail has been essentially debunked. It doesn't seem to happen. You get integrase resistance when you break through cabotegravir PrEP at high concentrations, not at declining or low concentrations. So the cover the tail issue is kind of going away, but the cover the nose issue is looming large, and no one knows the answer. What do I think the right thing to do is? I think a week is probably reasonable. I don't know that we need to go out to a month, but if somebody chose to do that, I wouldn't say they were crazy.
Okay, I think we're out of time and we don't want to get between us and lunch, so we'll take one last question from the audience, but you'll have to come up to the microphone because we can't hear you back here.
Is it okay to start a patient on cabotegravir if they want to, if they don't want to take pills?
So the oral lead-in is optional. So you're not obligated to do that and use the pills in that way. If they're categorically refusing to ever take pills, I would be anxious because if they're late for an injection, you're going to need to try to bridge them with something. However, if they're at risk and you're worried about them acquiring HIV, you have to make an individual decision with the patient in front of you, what the risks are of using cabotegravir, knowing you're never going to have that safety net if they're late for an injection. Is the harm reduction approach still to say, I'm going to do this, and if you're more than a week or two late for your injection, you have to use condoms. You have to.
Okay, thank you very much, Dr. Landowitz, and thank you for all of your attention. I am assuming that lunch is out in the lobby, and we will see you all back here promptly at 1:20. We're going to start right on time, so thank you all.